Hello and how are you? Welcome to our session on during the infibulation procedure. My name is Winnie Parawa. If you're new here, this is a channel that focuses on lessons, lectures, and interviews pertaining to healthcare. And in this session, we are doing a series in support with the University of Nairobi, the Girl Generation, and ACAF, which means Africa Coordinating Center for Abandonment of FGM. So stay with me all the way to the end. So to follow more on the series of Ending FGM, you can explore our playlist looking at Ending FGM in partnership with ARCAF playlist or through the Gender and Sexuality playlist. You'll find more videos and be able to trace back on what we've been discussing in the details of FGM. So in this part of the video, I'm going to look more onto during the de-infibulation procedure itself, how are we going to conduct it? What is the right place? What is the right process to follow while doing it? In the previous one, we did preparation of the client before we could undergo the procedure itself. So in here, we are into the procedure and we are taking ourselves step by step on how to start. Having done the tools, having signed the consent, having cancelled the client, what else should we follow now into the process? So just to remind us the tools and the instruments, we have done this in the previous video together with the even photos of how all these tools look like. But in the list, we had the sponge holding forceps, the long curved artery forceps, small curved artery forceps, needle holders, stitch scissors, surgical blades and blades holders, curved operating blunt pointed scissors, dissecting forceps, both tooth and non-tooth, kidney dishes, gallipots with sterile swabs. We had sterile gloves, dilators, syringes and needles for injections, local anesthesia drugs, absorbable sutures, lubricants, sterile towels or Macintosh, antiseptic solutions, receptacles, soap and water for hand washing. So this is a summary of the tools that we need, and I have also emphasized in case you're working in a resource limited setup, sometimes you may just assemble the main instruments that can help you perform the procedure, making sure that you observe all the needed steps. We understand that we don't work in the same well-equipped setups. So during the procedure now, how do we start? So in the first step, we are told ask your patient to lie comfortably on her back on the examination table. While asking, ensure that you have established total privacy and confidentiality. But also wash your hands and put on gloves. So strict aseptic precautions should be observed throughout the procedure to avoid infections and to avoid also putting the client at risk. A sheet may be placed covering her abdomen. This is to also emphasize more on the privacy, and ensuring that the client is comfortable enough. So the position we are adopting here is the lithotomy position because we will want to view adequately the perineum area, the genital areas to both confirm the type of FGM that the client went through to see the extent of anatomical changes before we can start to introduce the use of instrument and any chemicals on our client. So in the lithotomy position, so the vulva is cleaned with antiseptic solutions. So in this case, we want to ensure aseptic technique. We want to ensure the area is cleaned up very well, eliminate any pathogens, eliminate any potential infective agents. And so we need now to start using our antiseptic solutions. And so we shall do the vaginal swabs and cleanliness before doing anything on it. Then palpate the scar tissue in order to identify any underlying structures. So you want to confirm if the clitoris was still maintained where it is, the urethral meatus, how is it established and how does it look like. So in that, establish all these structures by palpating through the scar tissue. Then gently introduce your index finger or both your index and middle fingers. This is because we want to check the tightness of the opening, and in this case we can also use the dilator. So remember the dilator that I mentioned earlier, that in case you don't have it or you are in a resource scarce area and you don't have a dilator, you can just replace that with the index and the middle finger to check on the tightness. So into our next steps, we look at now applying the anesthetic medication. Here we are going to do local anesthesia. So we shall introduce the local anesthetic into the area, and you're going to target two parts. So we are going to target where the cut will be made along the scar and in both sides of the scar. So when we do a checkup of the area, we got the scar tissue, where most of the time is at the midline or at the middle, and that should be our target area for application of the anesthetic or the local anesthesia. Then we got to do on both sides of where the scar is, so on the lateral sides of the scar, and then you can concentrate more on where you want to do the incision or where you want to do the cut. So we target such areas, and then after doing that, now we head into the incision part. So with your finger or dilator under the scar area, carefully introduce the scissor in front of your finger and cut the scar alongside your finger to avoid injury to adjacent tissues or to the baby if this procedure is happening during second stage or during childbirth. So a vertical incision is made with a curved tissue scissor anteriorly along the midline of the scar towards the pubis to expose the introitus and the urethral meatus. So here is a demo of how the line should move upward. So we shall move along the midline. So here to remind us, where you don't have a dilator, just go with the two fingers, the index and the middle finger. And while you do a check of the patency of the vaginal opening, then you shall be introducing the scissor also and moving upwards to make the cut. So once you have made the incision, it's now good that you inspect the edges for any bleeding points and perform hemostasis if needed. So remember, we made an incision going upwards, and when we were making the incision, we were successfully able to expose two parts. That is the vaginal opening, the urethra, and the clitoris. And we expect that if it's successful, these parts should come out clearly. But now we shall end up with cut edges, and we need to check these cut edges if there's any form of bleeding that is happening here and conduct hemostasis interventions. Now, after we have separated and we have clearly inspect our edges, then it's good to suture now the raw edges separately using interrupted absorbable suture to prevent hemorrhage and also to prevent adhesion formation during the healing process. So we shall have interrupted sutures. So here we shall use now our sutures, the absorbable sutures that we have set in our instruments, and we get to make the interrupted absorbable sutures, that is, or stitches. Then after that is we can now prepare our client for the next steps. That is, don't forget to issue paracetamols or painkillers to just control the pain, but also we give more advice on what called the post procedure management that we shall come on later. But that is critical that after this you don't just leave the client but move forward and give more management steps that the client needs to do. So we are advised, however, that if de-infibulation is performed during delivery, the incision should be made after administration of a local anesthetic drug or anesthesia. It's very interesting that again in resource limited hospital, sometimes even delivery interventions like episiotomies are actually being given without anesthetic drugs. It's really important that before the delivery and the mother is in really extreme pain, it's really critical that local anesthesia is applied on the perineum before doing the de-infibulation on a mother who is actually in second stage. And suturing of this part of the cut edges after the mother has successfully gone through the delivery, it is therefore important that after you have done the infibulation on a mother who was on the delivery stage or during the second stage, you do the suturing after the mother has completed the delivery process safely and has settled down. And if there's no much bleeding, sorry, which is normally commonly the case, it is good that you also do suture the edges with the interrupted sutures. This is to prevent adhesions and to ensure that healing properly happens. So after the infibulation, delivery may be possible, therefore, without any episiotomy. So this is a critical information to note that once we have successfully taken a mother through de-infibulation, it is good to note that we do not have to push this mother through an episiotomy because we expect already that the opening will be adequate enough for the baby to come out or to pass through as she goes through the uterine contractions. Then after successful de-infibulation procedure, it's important to remember to clearly document the procedure in the patient records so that for future references, this case can be referred to. If there will be further management, the intervening healthcare worker can refer again and make any improvement or any needed intervention based on the needs of the client at that time. So here is a summary of the de-infibulation procedure. And so just to remind us, in the first step, we said assess the area or assess the perineum area, establish the parts along the scar tissue or along the midline, get to feel where the clitoris is, the urethral opening is, establish all these key parts before we start applying the anesthetic drugs. So we need to check the opening. So here we shall get to use our dilator or the two digital fingers to just check. And then after applying the local anesthesia, then we can now introduce the incision or the cut along the midline to expose the parts, that is the urethral opening, the clitoris, and even properly expose the vaginal opening. And after that, we said, don't forget to control bleeding if the lady is bleeding on the cut edges, and also to do the interrupted sutures to just allow proper healing to prevent also further bleeding after the procedure. But this is not the end. After this, the lady will need to go through post-procedure management, and we shall discuss that in details in the next video. So thank you so much for staying all the way to the end. Please like our video, leave a comment, share this in the platforms that you are in so that others can also understand about FGM and the interventions and the prevalences and the burden of care that is in the community, where we can all work together to just stop the practice of FGM in our communities. And don't forget to subscribe. If you're a returning subscriber and you've not subscribed, kindly please remember to do that. And if you're new here, just to repeat, my name is Winnie Barawa, and I'm so glad that you've joined our learning community. Till we meet again in our next lessons. Bye bye.